I'm so happy you could join us for the presentation of CardioSentinel from Purdue University. I'm the creator, Kaushik Loud. Om Sarve Bhavantu Sukhina, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kashchit Dukh Bhaga Bhavet. Our intention is service. We feel that a lot of the clinical research is incorporating data from the Western countries. We want to have Indian physiological context included in the research. We want data about Indian patients and make the results relevant to Indian people. I want to start off with a very sad event, and that would illustrate the failure of episodic testing. Dr. Chandrasekhar Pakmode was a very well renowned neurosurgeon, and he passed away in January 2026. Many ministers and people of significance commented about his passing with distress. Government Medical College and Hospital Nagpur Medical Superintendent Dr. Govt said his ECG was done 3 days ago and it was normal. And despite immediate intervention by his wife, Dr. Manisha Pakmode, and a team of cardiologists, even after 2 hours of sustained efforts, he could not be resuscitated. The current crisis is the fragmented data and lost context. Episodic fragmented care, patient interactions occur as isolated encounters with minimal continuity across visits or institutions. We're taking snapshots. Clinical data is captured as single-point observations lacking deeper physiological context. We don't have the longitudinal tracking, structured follow-ups, scheduled diagnostics, and standardized monitoring protocols. If we take a look at this patient's data, which was taken today, for example, if we look at the blood test results or her ECG or blood pressure, etc., given her age and given the demographic average data, it might be construed that she's okay. But if we look at the bigger picture, like 2 years ago, 1 year ago, and now, we can see definitely there have been changes in her BNP, troponin levels, her lipid profile, and of course, her BP, etc. And this would warrant a deeper look into her health and maybe change the medication that she is being prescribed. This is the advantage of the looking at the longitudinal data. Critical variables need to be linked for modeling the disease in the correct manner. Things such as the age, genetic predisposition, how the disease is progressing, comorbidities if they exist, and of course environment, pollution, stress, behavior, diet, exercise, smoking, alcohol, drugs. Ultimately, the consistent monitoring identifies early risk, time matters, and the trends tell the truth. Technical challenges towards ameliorating the same would be infrastructure limitations. Many healthcare institutions lack the storage, computing capabilities, personnel required to manage these high volume data streams of valuable data such as ECG, waveforms, imaging, continuous monitoring feeds. And we'll be talking more about that and giving specific examples, for example, at JJ Group of Hospitals, which would account for like 30 terabytes of data for just the ECG. Data extraction deficit. Diagnostic devices generate rich physiological signals, yet there is limited capability to extract, normalize, and store the clinically relevant parameters in structured formats. In India, fewer than 40% have mature electronic management record systems, and the majority of device-generated data, ECG, ICU monitors, ICDs, remain unstructured, non-integrated, or stored in non-compatible formats such as image or PDF, which renders the extraction of actionable intelligence from this data nearly impossible. Lack of cross-referencing system. There is no scalable mechanism to correlate the patient-specific data with established markers to trigger warnings or clinical review. But we have a solution in mind. The point of entry would basically have a standardized intake process with the demographics, baseline clinical information. It would be done through the CardioSentinel app or at the kiosk itself, which will be supported by a clinical health worker. We would have scheduled follow-ups and established a longitudinal screening process for chronic conditions, diabetes, hyperlipidemia, atherosclerosis, recognizing that these are progressive multi-year diseases. And we would have structured and well-scheduled diagnostic inputs, such as HbA1c, KLFT, KFT, CBC, BNP troponin tests, lipid profile, and all the different ECGs, MRIs as needed. Now let's take a look at the ECG signal pipeline, morphology of our capture. So we would have a process for high resolution ingestion with adaptive filtering to remove power line interference, baseline wander while preserving the raw morphology. We have advanced algorithms such as NeuroKit and BioSpy, which would utilize industry standard libraries for probabilistic peak detection. And beyond the peak, which usually just counts the heart rate, our system would map the entire beat, PQRST, ischemia vigilance, real-time ST tracking. If a patient starts to elevate STEMI or depress ischemia, the system would flag it instantly. Detection of abnormalities specifically tuned to capture bundle branch blocks and T-wave inversions. No data would be left behind. Ectopic beats, PACs, PVCs are not discarded as noise. They are fingerprints and stored as critical clinical data. So these are some of the diseases and the markers they show on the ECGs. This is, just included. And then we would have the feature-based storage and contextual reconstruction. So we're talking about the skeleton storage model. We would be taking 12 to 15 discrete data points per heart cycle, amplitude and timing, rather than the 500 plus raw voltage points. And thus we would be achieving greater than 90%, probably like 92 or 94, reduction in the footprint for the data, enabling years of longitudinal storage on standard hospital servers. And we would be including pharmacological metadata integration. Every data packet would be time synced with the medication log, example, beta blockers, digoxin, immurodone. This ensures that a slow heart rate or a prolonged QT interval is interpreted in the context of the patient's current medication profile. And we would have high fidelity reconstruction with cubic spine interpolation. And because of this, we would have the polarity and amplitude, and the reconstructed wave will accurately reflect the inversions and abnormal shapes which would indicate the disease or the progression of disease. We would have clinical validation, reconstructed signals maintain the diagnostic truth, and we would have the validation metric, the target of greater than 98% correlation between raw reconstructed waveform for rhythm and morphology analysis. So this was illustrated in this picture over here. Instead of taking the data from the ECG machine and storing the bulky raw file, which can be several terabytes in a hospital the size of JJ, we would instead be using the CardioSentinel processing methodology, wherein we would be using our advanced libraries to extract the relevant data with a 90% reduction in the amount of data. Remember, this is not compression. This is not like, taking the data and compressing it. It is in fact, like I mentioned, the skeleton storage model based on the number of data points that we're taking. So it would take much more lesser amount of storage space, and on demand by the clinician, the ECG would be recreated on the dashboard. Also, like for example, if the ECG is directly not available in the soft format, the image of an ECG can be utilized, image to data conversion can be utilized using advanced algorithms, and we would digitize the ECG records for secure cardiac research. So now let us dive a little bit deeper into the ECGs. So how much actual data is coming in from ECGs in a hospital the size of Sir JJ? According to official statistics, JJ Group, Grand Medical College, Sir JJ Group of Hospitals, sees around 5,000 patients a day. It's like 1.6 million or more in a year. And has, on an average, more than 150 patients in the different ICUs. I'm using a conservative number. Realistically, 35% of the OPD patients would require a routine ECG for a duration of 10 seconds to 1 minute with a 12-lead ECG, diagnostic purposes. And 100% of ICU patients are under 24-hour constant monitoring with at least a 3 or 5 lead ECG. So how much is that in terms of data? For the OPD, with the 5,000 patients, 35% of them need an ECG, we will be talking about 2.45 gigabytes per day, and this translates to around 900 gigabytes, 1 terabyte per year. Now, 1 terabyte is the raw data. In clinical terms, this is 3 terabytes because you have triple redundancy required by the law, American and Indian, and then you have all the systems in place, 24/7 backup, higher quality equipment, etc., which comes out to maybe a pretty expensive number, approximately 5.5 lakh rupees. But we'll come to that later. ICU patients, like, assuming 150 per day, and that data comes to around 27 terabytes in a year. So totally around 30 terabytes of data in a year just for the ECG, pure ECG data from Sir J.J. Hospital. So let's take a look at how exactly this would be converted. What does it look like? This is one of the things that I was told by clinicians from Purdue would be of great interest. So let's take, the CardioSentinel system acquires a high-resolution raw ECG signal, and it represents a standard 3-second snapshot captured at 500 hertz. We have annotated the PQRST waveform, and through the complex morphology is present, the signal is bulky. There's a signal. Now, let's go to the NeuroKit 2 extracted feature set. The core message is simple. We are moved from recording voltages to recording ventricular truth. Beyond simple compression, the delineation, we are saying that most digital systems look for the highest peak to count the heart rate. Our system uses NeuroKit 2 to delineate the heart's anatomy. It identifies the exact start and end of every PQRST waveform. We don't just compress a signal, we understand its structure, morphological coordinates of intent. Instead of saving thousands of redundant dots on a flat line, we focus on the coordinates of intent. If a patient has a T-wave inversion, a sign of a hidden heart attack, our system sees that polarity change as a specific digital vector. We preserve the red flags while discarding the useless noise. The high-fidelity feature set. The output isn't just a graph, it's a rich database. Every heartbeat is stored with its own fingerprint. That includes the polarity, is the T-wave upright or dangerous? Width, is the QRS widening, indicating a bundle branch block? Ectopic tagging, are there extra beats, PVCs, that predict future heart failure? The economic aspect. By transforming the signal into these digital vectors, we maintain 100% diagnostic integrity while reducing the data footprint by over 10%. This is how we make it financially possible for a government hospital to keep a citizen's entire cardiac history for 10 years without needing a massive data center. Now let's take a look at this data set. The section A shows the system log, the longitudinal monitoring stream. What does it represent? This is the high-level view. It shows a continuous stream of heartbeats, indices 001 through 030. The alert mechanism point, take a look at the beat 003. While the other beats are tagged as normal with standard heart rates and QRS durations around 92 milliseconds, the system has flagged beat 003 in red with an alert status. The critical observation in here is that even in the summary view, the system identified a premature ventricular contraction, PVC, because the duration of the QRS spiked to 148 milliseconds, indicating a wide, dangerous beat. Now, if you look at section B, the deep dive, with the multimodal feature vector, this represents the under the hood engineering validation. It shows exactly what NeuroKit 2 algorithm extracted for the specific red flag beat, the 003 beat. And if we look at compare the clinical versus digital, we look at the RR/INT, which is 450 milliseconds, and the QRS duration 140 milliseconds to the clinical reality of a PVC. But if we look at the pharmacological context, notice the column med_context ID. It shows M/102 beta BI. This tells a doctor that the patient is on beta blockers, which is critical for interpreting why these ectopic beats might be occurring or how the heart is responding to medication. So if we look at the fidelity check on the far right, we see the original PVC versus the reconstructed skeleton. This is the strongest technical proof, and we will have a better view of this. We have a 98.4 correlation proving that the skeleton model does not lose the diagnostic shape of the waveform. Now taking a look at the guardrails of reconstruction. Moving from extraction to visualization. We have shown how we extract the data and how we add context in the previous two slides. Now we show how we give it back to the doctor. This isn't just drawing a line between dots, it is constrained reconstruction, eliminating diagnostic hallucination. A common fear in artificial intelligence is hallucination. The system sees something that isn't there. We prevent this by using constrained cubic spine interpolation. Our algorithm is physically forced to follow the vectors we store. If our database says the T wave is negative, the math is forced to draw an inversion. It cannot guess or smoothen out a dangerous signal into a normal one. To prove the 90% efficiency is truth-preserving, this is where our 90% data reduction becomes a clinical advantage. By filtering out the noise of the baseline and only keeping the truth of the fiducial coordinates, we ensure that when the cardiologist reviews the record, even years later, the reconstructed wave they see is diagnostically identical to the raw original signal coming out of the ECG. The final review, the pharmacological window. Finally, when the doctor views the reconstructed wave, they are not looking at it in a vacuum. They see the medication log right next to it. This pharmacological window ensures that the review is not just a visual check, but a comprehensive clinical assessment. So let's take a look at the fidelity benchmark by a side-by-side comparison. We have the visual challenge. We have talked about the math and the data reduction. Now I want to show you the result. On this slide, you see the raw signal we captured and the reconstructed wave built entirely from our stored fiducial vectors. To the human eye and to a diagnostic algorithm, they are functionally identical. We will take the case study of beat number 2. Look at beat 2. This beat shows a clear T wave inversion. In a typical low resolution or overly compressed system, the inversion might be smoothed out, but because we stored the negative polarity vector, our reconstruction accurately reproduces the clinical red flag. A doctor reviewing this years later would see the ischemia clearly. Case study beat 3, capturing the emergency. If we look at beat 3, the premature ventricular contraction we talked about before, it is wide, premature, and it has a completely different shape than the normal rhythm. Even with 90% reduction in data, our skeleton preserves the precise width and timing of this ectopic beat. We aren't just saving space, we are saving the events that matter most in an ICU. The gold standard, 98.4 correlation. We don't rely just on visual checks. Our mathematical validation holds a 98.4% correlation between the original and reconstructed signals. This exceeds the threshold required for clinical decision making. We are providing diagnostic grade fidelity at a fraction of the traditional storage costs involved. The integration of context. And as you see at the bottom, the waveform is presented alongside medication context M/102. The doctor isn't just seeing a PVC, they're seeing a PVC in a patient already on beta blockers. We talked about that before. This is the complete clinical picture. And now we would like to extend the monitoring integrity to other diagnostic sources such as Holter monitors, ICDs, or ambulatory telemetry. We would be using similar kind of data extraction techniques to be able to get the very valuable data from these sources and utilizing them in the dashboard for the doctor for his diagnostic purposes. So now comes the execution strategy. Our fundamental idea is that structure precedes prediction, and systematic structures definitely save lives. I lost my first child to SIDS, and I worked very intensely on infant health for a long time. I met a lot of very successful scientists in this field. One of the most influential ones was Dr. Hannah Kinney from Harvard Med School, who worked with the Boston Children's Hospital. She is she's a very larger than life figure in this arena, and but the program that she created, Back to Sleep campaign, that reduced infant mortality from, say, it's 75% on an average across the world, in some places more than 92%. And she did that through a very simple, structured message: a crib, sleeping space for a baby, without pillows, toys, clutter, or co parent sleeping. She did not need the public to understand the complexities of autonomic nervous system failure to save millions of infants. She just provided a framework for safety. In the same vein, we acknowledge that even before full AI prediction is achieved, the simple act of structured monitoring and regular screening can save millions of lives. This structured approach delivers immediate clinical value, independent of advanced AI deployment, and operates entirely within the existing regulatory and institutional framework. This structured monitoring and regular screening will provide us the data needed and indeed the impetus to take it to the next generation scientific achievement of artificial intelligence aided predictive modeling for cardiovascular disease. So, the core implementation architecture: we would have the unified health identity layer linking demographics, comorbidities, and medications. We would have the standard interoperability architected for full compatibility with national framework. For example, in India, there would be ABHA using HL7 FHIR, fast healthcare interoperability resources, for data exchange, and DICOM ECG standards for waveform metadata, which would basically mean that the system would be independent of the vendor. It could be plug and play in any hospital system across the country. And we would have dual sources of data acquisition from the clinical resources such as ECG machines, Holter devices, diagnostics, and from the patient themselves. They could upload reports via mobile apps, images, PDFs, and that would be, we would have the data extraction from that. And of course, their historical records. We would have data quality gatekeepers in place to ensure that the quality of data that we're getting is maintained. We would have temporal structuring, clinical focus on detecting disease progression, circadian variations, etc. The physiological signal prioritization and feature extraction, like we talked a lot about this, prioritizing ECG, Holter monitor, and vital signal streams for deep analysis. The pilot implementation would be done at a departmental level, cardiology, ECG, for example, and it would operate on existing hospital infrastructure. Data governance: all identified data will remain with the originating hospital. Operating learning user interface evaluation: we would be collecting feedback from clinical staff regarding workflow integration and alert fatigue. We'll talk more about that with the human factors aspect of it. Iterative refinement: pilot findings are used to tune the data quality gatekeeper and the feature extraction sensitivity. So overall, the pilot phase implementation would look something like this. These are the 7 points that we talked about right now. One important note to include is that we intend to incorporate NVIDIA Hopper Blackwell Tensor Core architecture, which provides hardware-rooted encryption and secure and enclave processing for sensitive data during analysis. This is a very robust way of protecting health records and patient identity, and adheres to every standard globally for patient privacy, and we definitely want to make it a part of our system. We will be United States Food and Drug Administration 21 Code of Federal Regulations 820 compliant for Class 3 medical devices, which would include compliance with the European Medical Association ISO 13485 as a Six Sigma Master Black Belt. And I believe that ISO 4971 is perhaps the most robust form of quality management enforcement. The risk management system protocol is amazing. And of course, we would have the ISO 60601 for safety. We would have the typical design control and validation. We would mandate traceability from user needs, design inputs, verification, and clinical validation. And if you've been working in the medical device sector, and if you've attended any hearings in a court, then you understand that one of the most important things that a federal judge focuses on is the CAPA, corrective and preventive action, at the time of any class action lawsuit, or any lawsuit for that matter. which would which would involve continuous error reduction through closed loop feedback, complaints, audits, and real world performance data. These systems are resisted by a lot of engineers and clinical staff, but then these processes and procedures are in place because the one thing that a human being is guaranteed to do is to make mistakes. And these procedures help, they do not eliminate it completely, but reduce it as much as humanly possible, which is what a judge or an FDA official is looking for. We would be adhering to the AAMI HE75 2009 US regulatory expectations. We understand that the three failure pathways are design and manufacturing flaws, inadequate training, and real-world use stress, fatigue, urgency, cognitive overload in an intensive care unit or an operating room. We would have the front-end research, contextual inquiry in real environments, iterative prototyping cycle, and design refinement outcome to creating a very robust and usable system, which is very easy to pick up even for the patients, the nursing staff, and the clinicians working on it. We will be adhering to every patient privacy and data protection laws, both in India and in the United States. The relevant laws are mentioned over here. Now let's take a look at the actual system anatomy, the operational infrastructure. We feel that a clinical ingestion kiosk would be necessary, which would be a dedicated terminal in the cardiology OPD ward. It would connect to the existing ECG machines. We would have the CardioSentinel patient app, which would be used for longitudinal data entry and also uploading the pictures and PDF of their past diagnostic reports. And then we would have the secure data vault with a centralized hospital governed database that would merge the clinical data with patient recorded data to create the golden longitudinal record. So this is what we envision. Of course, this is without any human factors research done, the clinical dashboard. And I picked the name Tanaji Malusare because he's my hero. And we see here his information about his ECG, his HRV trends. With a click, the doctor can look at his ECGs from 3 years, and the NeuroKit 2 feature set is available in the tabular format. The pathology lab results are available for a period of 2 years or more, and the doctor can see the progression of how his LDL, HDL, HbA1c, serum creatinine is happening over the years. And then we have the vitals and lifestyles and this sleep circadian pattern. So this would give a very holistic picture to the doctor for making the correct diagnostic decisions, and if needed, to change the medication. So let's take a look at the quantifying operational and economic impact. Let's take a look at the JJ hospital model. So like we said before, the outpatient ECG for 500 hertz, that would be approximately 1 terabyte. The cost for that would be around 5.4 lakh rupees. Now, if we reduce it by 92%, then we would have a size of around 72 gigabytes, and we require 43,000 rupees. Similarly, for ICU monitoring, instead of 27.4 terabytes, it's only 2.2 terabytes. Similarly, with Holter ICD, we extrapolate 500 terabytes, and that reduces to 40. So total savings would be very, very significant. One important thing that that I anticipate is that the cost, for example, for the outpatient ECG 1 terabyte, how is that 5.4 lakh rupees? So we have to understand that this is using enterprise SAS, high DWPD equipment. So the drive is around 7 to 8 times the cost compared to what commercial computing systems use. The uptime guarantee has to be 99.99% clinical standard required. And this is as per the laws that Indian institutions have in place. The data redundancy will have to be 3 times. So even though it is 1 terabyte, it would actually be 3 terabytes with RAID and offsite backup. The security would be AES 256 plus DPDP Act compliant. The lifespan would have to be 5 to 7 years, 24/7 operation, and the support has to be on-site 4-hour SLA. So there's going to be staff involved in maintaining it. And the cost per terabyte would be 1.8 lakh rupees, and that is times 3 for the redundancy, coming to 5.4 lakh rupees. That is where that number comes from, if anyone is interested. So now we're talking about a digital transformation, the smart hospital intake workflow. We would have a unified intake, patient registered, patient comes in into JJ, or like they would register using the app, and with the UPI integrated, they would make the fee payment, the 10 rupees, whatever they need to pay, bypassing the physical queues. Like, I have been to KEM hospital in the mornings, and it's a very interesting affair. You stand in line for a long period of time to pay the 10 rupees, get a pauti, and with the pauti, you stand in line again with people pushing and shoving, and you're always at the wrong counter. Then you have to stand in line again and then get the papers, and then you have to go to the clinic, show the papers, and then the procedure starts. And if you misplace your case papers from the previous time, the doctors were usually angry at you, and then it's like you start over all again. And that is again the case for the lack of episodal clinical review versus longitudinal screening. So that would be eliminated by this unified intake procedure, and it would be on a QR based navigation. When the patient is registering and paying the fees at the at the hospital using his app, they would generate a dynamic QR code, and then when he reaches the hospital, he can show the code at the kiosk at the ward, and that would print out his digital case paper and notify the physician. And the integrated ecosystem would mean that the physician dashboard is ready when the patient comes in, with real-time access to reconstructed ECG vectors and historical trends and all the good stuff we talked about, his blood test results and everything else. And the physician in this dashboard can prescribe the new medication, write his notes, and the digital prescriptions would be linked to the patient's preferred pharmacy and health insurance for claims processing. This is, hopefully we'll get there. I mean, I'm very optimistic about it. The evolution of intelligence from structured monitoring to prediction-driven care. So what we talked about till now has been pretty much phase one of our efforts. We want to do the structured clinical intelligence for about 24 months. The foundation would be the longitudinal integration of ECG labs and diagnostics into a unified patient profile. The contextual insights would be obtained, shift focus from isolated events to disease progression trajectories. And this would increase the operational efficiency, use the advanced algorithm, and the outcome would be enhanced clinical visibility and proactive risk identification. Now, this is phase two, predictive modeling and decision support. The transformation would leverage the structured longitudinal dataset to train predictive models. We would have the option of early intervention because we could be able to detect physiological deteriorations before clinical symptoms manifest. We would have data sovereignty, models trained in the hospital-controlled India-based infrastructure, strict privacy, preserved parameters for research, no identifiable data leaves the premises. Outcome, a transition from reactive monitoring to prediction-driven care. The 24-month horizon, building the foundation for predictive intelligence. The data accumulation milestone goal to establish a high-quality longitudinal data set within 24 months. The outcome, sufficient data volume and integrity to initiate clinically meaningful AI model development and validation. Global leadership. This would establish India as a primary hub for AI-driven cardiovascular research and innovation, leveraging unique real-world datasets. So that's my time. Thank you so much. My contact information is here, and that's my most favorite person in the world, my son Thor Bholanath Lode. He's 100% disabled, autistic, but he wins national maths championships. He's a genius guy. So once again, thank you, and God bless.